Selamat pagi, salam sejahtera pada semua. Jadi sekarang dah pukul 9.30 pagi, kita akan mulakan kita punya CME berkaitan tentang satu topik iaitu Lipaemic sample, what to do. Rasa topik ini agak relevan kepada semua dan kita nak pastikan objektif pada hari ini supaya semua yang hadir pada CME pagi ini tahu bagaimana nak manage ataupun nak uruskan sampel yang mempunyai Lipaemic sampel yang sangat Lipaemic. Jadi bagaimana nak buat dan how to handle it. So untuk CMA kita pagi-pagi ini akan disampaikan oleh Dr. Muhamad Syahmi. Dr. Muhamad Syahmi adalah pakar patologi kimia yang baru di Hospital Pulau Pinang. Beliau merupakan graduan daripada Universiti Malaya. Jadi tanpa melengahkan masa, saya menjemput Dr. Syahmi untuk menyampaikan CME yang bertajuk Lipaemic Samples What to Do.
Hello. Assalamualaikum. Selamat pagi, salam sejahtera semua. Terima kasih Dr. Jamsani atas introduction tersebut. So hari ini saya akan present tentang, minta maaf, saya Dr. Muhammad Syahmi, the new clinical pathologist in Hospital Pulau Pinang lah. So nice to meet all of you here. So today we're going to discuss about how to handle Lipaemic samples and what we need to do. So actually this topic is not a new topic, and I'm sure some of us knows the exact procedure for handling Lipaemic samples lah. Okay, so I will start my presentation with a case. This is actually a true case that happened in one of our district hospitals. So this is a 50-year-old man with no known medical illness. He is an alcoholic and smoker. He presented with chest pain and was treated as unstable angina. So routine biochemistry testing was ordered, and it was not suitable for analysis due to severe lipemia. However, they are able to produce an FBC result, which is show that HB is 21 gram per liter with hematocrit of 50%. So the patient was given IV hydration and venesection was done. So venesection is actually a procedure where we remove volume of blood from the patients. It's quite similar with blood transfusion, but for these blood products, we will discard it because it is a pathology blood. So it will not be used for other patients. So repeated FBC show that hemoglobin is reducing in trend from 21 to 19 to 15 gram per liter. So subsequently, he was discharged home without a proper biochemistry test result available. So actually from here we can see that it's not a good practice for discharging a patient without know the exact true causes of the Lipaemic samples. So the patient was presented again in the same months for the similar complaints. So same also, the routine biochemistry test ordered still not suitable for analysis due to severe lipemia, but they're able to produce a FBC result with HB of 17 gram per liter with hematocrit of 42%. So venous section performed again, but at this time they noted that the blood showed milky appearance, as you can see from the figure here. So what actually happened for this patient actually? So as introduction, lipemia is a turbidity of the sample caused by accumulation of lipoprotein particles. So it can range from, as you can see from the figures, it can range from a cloudy appearance to a milky appearance of the plasma and to a pinkish whitish appearance of the serum. Why there is a different appearance of this Lipaemic sample? Because it depends on the type of the lipoprotein particles increase in the samples. So bear in mind, the Lipaemic samples can aggravate the hemolysis. That's why you can see a pinkish, whitish plasma like these figures. So overall frequency of these Lipaemic samples range from 0.5 to 2.5% only. So it's a low prevalence, but the effect of this Lipaemic sample is actually sometimes it's catastrophic. So what is lipoproteins? As the name implies, is a lipo and proteins, which is made of particles of lipids and proteins. So the function of lipoproteins is to help to carry cholesterol throughout your bloodstream. So as you can see from this figure 1, there is many different types of lipoprotein, from chylomicrons, VLDL, LDL, and HDL, and there is one intermediate here, which is the IDL. So chylomicron and VLDL has the bigger size, but they have a low density. That's why they will float when you do the centrifugation process. While HDL has the smaller size but have the higher density. That's why after you centrifuge the sample, it will not float at the upper part. So why there is a difference in this properties of this lipoprotein? Because it depends on the composition of the lipoproteins itself. So chylomicron actually have the highest amount of triglycerides, followed by VLDL. So LDL and HDL has the lowest amount of triglycerides. So this triglyceride actually give the lipemic appearance of the samples. So next we move to the causes of lipemia. So the most common one is the pre-analytical causes, which easily can be prevent, which is the non-fasting samples. That's why for certain blood, we need to ask the patient to fast at least 8 hours before the blood takings. So there is also primary disorders and secondary disorders. Primary disorders mostly is genetic disease, like the Fredrickson type 1, the hyperchylomicronemia, type 4, the hypertriglyceridemia, and type 5, hyperlipidemia. And there is also due to secondary disorders like diabetes mellitus, alcoholism, hypothyroidism, acute pancreatitis, chronic kidney disease, MAFLD, the metabolic syndrome associated fatty liver disease, HIV infections, and some medications like intravenous lipid emulsion therapy, the TPN, glucocorticoids, antiretroviral medications, and also estrogens. And they also have some reported case of other causes like ketogenic diets, the low carb and high fat diet, which can lead to lipemic samples. So next I will discuss about the mechanism of this lipemia interference. There is actually 4 mechanisms of lipemic interference. So the most common one is the interference in the spectrophotometric methods. Spectrophotometric method means we use lights to detect the analytes value lah. So most of our routine tests use this spectrophotometer. So how can this lipemia interfere with spectrophotometric methods? Because these lipoprotein particles actually can absorb lights. As you can see from this figure, you just concentrate at the gray slope area here at the back. So this is actually interference by the lipemia. So the amount of light decreased from 300 to 700 nanometer with no specific absorption peaks in between. So therefore, methods that use lower wavelength, which is about 300 to 350 here, is more affected by lipemia, especially the LT and AST, where they measured at 340 nanometer. So we come back to this figure. Actually, the red one is the hemolysis interference. So as you can see, hemolysis have dual peak. It can interfere at this 400 nanometer and 550 nanometer. But icterus have one peak only. They can interfere from 400 until 550 nanometer. So the lipemic interference is not that specific. The interference at the initial part is overlapping with this hemolysis and icterus. That's why our automatic analyzer will measure at this area for the lipemic index. So next mechanism is the non-homogeneity of the samples. So in order to get the serum or plasma, we need to centrifuge the patient samples. So after centrifugation, the particles will distribute according to their density. So as I told you before, chylomicron has a bigger size but low density. That's why chylomicron and VLDL will therefore located at the top of the tube. As you can see from this figure, will located here. as compared to the so hydrophobic analytes are distributed in this liquid phase, and hydrophilic analytes, like electrolytes, are distributed in the middle parts. So as you can see from the figures, if the probe take the samples at this hydrophobic phase, it will lead to falsely decrease of hydrophilic analytes which accumulate at this area. So vice versa, if the probe take the samples at the hydrophilic phase, it will lead to falsely decrease of hydrophobic analytes that accumulate at this area. Hello, sorry. Boleh tolong mute kan? Okay, terima kasih. So the third mechanism is actually the volume displacement effect. So this is quite common in our lab, which is the pseudo-hyponatremia. So normally the plasma consists of approximately 93% of water and 7% of lipid. So especially in the indirect potentiometry methods, which is the indirect ISE, it will result in falsely decreased concentration of electrolytes, which is the commonest one is the pseudo-hyponatremia. So this effect is prominent at triglyceride level of more than 70 millimole per liter. So as you can see from the figures, the normal plasma will have this 7% to 93% ratio, but in lipemic sample, they will have this increase of lipid percentage and reduce in plasma water percentage. Subsequently, it will lead to further dilution that will result in low reported sodium value, which is not a true sodium value. This is actually the pseudo-hyponatremia because of the limitation of the method itself. So how to resolve this interference? We can simply measure the sodium in the direct potentiometry methods, which is the direct ISE in the blood gases machines, because this type of method can measure the true concentration of these electrolytes. So the less common mechanism is the physical and chemical interference. So it can interfere with electrophoretic methods like in the capillary electrophoresis methods. This will result in abnormal morphology of the alpha-2 globulin fraction in the chromatogram. And then the next mechanism is interfering with the antigen-antibody reaction in immunoassay by blocking the binding sites on the antibodies. So it can cause falsely elevated or falsely decreased result depending on the nature of the reaction itself. So as you can see from the figures, if the patient has lipemic samples, when they form this aggregation, it will lead to increase of light absorption that will lead to increase of analyte value, falsely increase in the analyte value. So that's all for the mechanism of lipemia interference. Next, we go to the how can we detect lipemia. So historically, we use this visual detection, which is not that good because it's depend on the person itself and it's poorly reproducible. So lipemia can only be detected visually in the serum if the concentration of the triglyceride is more than 3.4 millimole. However, in full blood samples, we need to have a concentration of triglyceride more than 11.3 millimole per liter. So that at that level, we can observe it visually as a lipemic samples. That's why lipemia of the full blood samples often remains undetected. And then next, by using the triglyceride concentration measurement, so some lab use TG concentration measurement or rough assessment of degree of lipemia. However, the proportion of TG differs among lipoprotein subclasses and range between 50% in VLDL particles and up to 85 to 90% in chylomicron, as I told you before, and in this figure. So if you use TG concentration, it will reflect more towards chylomicron as compared to VLDL and also the other lipoprotein. So that's why the degree of turbidity does not correlate well with this TG concentration. So the most common one we use now is this automatic detection of lipemic index. So it actually based on the dilution of the sample in the buffer. and measurement of spectra in a wide range of wavelength. So I show you this figure before. So the machine will use a spectrophotometer to detect this HIL index. So absorbance is proportional to the amount of lipids in the samples. So there is a large heterogeneity between manufacturers in the wavelength used. As an example, AU series by Beckman Coulter use this area at 660 to 800. However, our Cobalt series use 660 and 700 nanometer. So why they use at the distal end where the amount is actually less? Because it does not overlap with this hemolysis peak and also icterus peak. That's why most of the company use this area for detection of lipemic index. So what is the advantage of this automatic detection is low cost, high speed, increased reproducibility, and shortening the TAT. However, there is few disadvantage. It can lead to false positive result in the presence of sample turbidity that is not caused by accumulation of lipids, like in high amount of protein in multiple myeloma patient. So this paraprotein actually can produce a similar interference with this lipemic samples. And there is also lack standardization of among manufacturers in reporting this L index value. Some use semi-quantitative and some use almost fully qualitative scales. Hence, this lipemic index can be compared between different manufacturers. That's all for the detection of lipemia. And next, we proceed to how we handle this lipemic sample and how we can remove it. The first is centrifugation. Bear in mind, this is not the normal centrifuge. The most recommended procedure is using the ultra centrifuge. This ultra centrifuge can obtain forces up to 100,000 to 2 million RCF. If you want to use RPM, you need to convert it. However, it is costly. That's why I don't think any KKM hospital has this ultra centrifuge machine. It's not a benchtop centrifuge. It's like on the floor machine, and it's a big machine. So don't mistaken this ultra centrifuge with this high-speed centrifuge, because high-speed centrifuge is actually a benchtop centrifuge, which has the force of 10,000 RCF only. So many articles have proven that this high-speed centrifuge can be used to remove this lipemic interference. However, it is less effective for VLDL particles and is more effective for triglyceride particles. For this VLDL particle, we need to use this ultra centrifuge to remove it. So how we do the centrifugation? We centrifuge at we liquid it into the epidurf tube and centrifuge at the 13,000 RPM for 15 minutes. So after centrifugation, the lipid layer of the top of the tube is removed, which is this area. The lipid whitish area will be removed, and measurement of the analyte is done in this middle part, the infraretin. However, bear in mind this approach is not acceptable for lipophilic analytes like hormones, drugs, and other hydrophobic substances. So the next steps you can use is extraction. Lipids can be extracted using polar solvents like polyethylene glycol, PEG precipitation. The cyclodextrin also a product which is called LipoClear. So we just combine this extract product with the samples, and then we centrifuge the samples. So particles will be precipitated at the bottom of the tube, and measurement is performed in a clear supernatant. So as you can see, this I show you the examples of how we do a PEG precipitation for macroprolactinemia samples. So PEG will bind with these proteins and lipids, and later it will be precipitated at the bottom of the tube. So we will measure the upper part of the samples, the clear supernatant. So the advantage of this extraction is very fast and efficient. However, it cannot be used for all parameters because there is a case report show that there is fictitious low result for inorganic phosphates, GGT, CKMB, and CRPA values. The last steps you can use to remove this lipemic interference is sample dilution. This type of procedure is especially used for the lipophilic analytes, which is the hormones, the drugs. how we dilute the patient is we must make sure that the samples can be diluted only enough to remove the turbidity interference, usually 2 to 3/4 of dilution only. So that we need to make sure that the analyte concentration remains within the analytical limits of the tested methods. So this type of procedure is probably the best approach for measurement of therapeutic drugs in lipemic samples. So next we go to the protocol. This is I get from a journal also where they show the general protocol or flowchart for management of lipemic samples. So if you have a sample, you need to confirm the degree of lipemia. Usually we can use the lipemic index, and then we need to make sure the test method principle itself, because different methods have different levels of lipemic interference. So usually in routine chemistry, the most commonest affected analyte is the AST and LP, which has the low level of lipemic interference, about 150 in Roche. That's why for this type of analyte, you need to remove the lipemic interference. So for some analytes that have a higher value of lipemic interference, you can just measure the samples and provide the formal lab reports. For analytes that have low level of lipemic interference, you need to have a protocol depending on the test requested. So as I told you before, you can use dilution for lipophilic analytes. You can do extraction or you can do centrifugation. And if the interference had been removed, you can proceed with producing the formal laboratory reports. So what can the district hospital and health clinic do? So bear in mind, rejection of samples is not always the appropriate ways, because it may cause harm to the patients. Same like the patient I showed before, the patient was discharged without having any appropriate routine biochemistry results. And lab staff needs to know the analyte's levels of lipemic interference, as the level varies between method of measurement and between analytes. That's why you need to see carefully in the product insert the level of the lipemic interference of each analyte. And lab staff should try to produce results by troubleshooting the samples. As simple as like pseudohyponatremia, if you have a ABG machine, blood gases machine, you can provide with verification of direct ISE to produce the true value of the sodium levels. And if you don't have the facilities like the high-speed centrifuge, you can refer the samples to the center with appropriate instrument for further measurements. So right now in the Penang states, only Hospital Pulau Pinang and Hospital Sempang Jaya has this high-speed centrifuge. So this is I just roughly show you the procedure you can do at your levels. So first you need to detect the lipemic samples by visual inspection or automatic lipemic index. And then you need to determine if the lipemia interference will interfere with the test result or not. So if it does not interfere at that level, you can proceed with measurement. But if it interferes with the result, you can need to know how to remove the interference. So if the interference is in the indirect ISE, you can simply do the direct ISE on blood gases machines. And if you don't have the appropriate instrument, you can refer samples to the center with appropriate instrument for further measurement of biochemistry results and also drugs or hormones tests. Minimally, you can make sure you send the fresh patient's serum or plasma, at least 2 samples, better, with the relevant clinical information. So I just share with you our hospital Pulau Pinang protocol for removing or handling of lipemic samples. So first, same also, we need to detect the lipemic index, and we need to know if at that level the lipemic interference will affect the test or not. So for IST test, you can simply proceed with verification using the direct IST methods. And photometric test, we need to proceed with high-speed centrifuge. How we do it? We transfer the plasma into Eppendorf tube and re-centrifuge using high-speed centrifugation at 13,000 RPM for 15 minutes. And then you need to pipette out the clear plasma and repeat analysis. Later, you need to see the reaction monitor. If it is okay, you can release the result. But if the reaction monitor is not okay, the result is actually not reportable. You need to produce a formal result with a comment of this sample is lipaemic and result cannot be produced. So we go back to our case before. The patient samples were referred to Center for Further Analysis. A high-speed centrifugation was performed. Analysis revealed severe hypertriglyceridemia, which is about more than 40 millimole per liter with total cholesterol of more than 10 millimole per liter. Subsequent biochemistry tests can produce an actual result. So the patient was started on lipid-lowering drugs, which is statin and fibrate, was referred to genetic clinic to rule out the primary causes. Lipid profile and cardiovascular disease risk assessment had been performed. Screening of other family members for genetic disease also, and do an ultrasound liver to exclude fatty liver. Lastly, take-home message. Lipemia interference, though has low frequency, less than 2.5% only, but it is a significant source of lab errors. So lab personnel should be aware of the influence of lipemia on the results of the lab test. So by right, written procedures for detection of lipemia, removing the lipemia interference and reporting results from lipemic samples should be available to lab staff in order to standardize the procedure, reduce the error, and increase patient safety. So that's all from me. Thank you. If you have any question, you can just.
Okay, terima kasih Dr. Syahmi. Jadi ada apa-apa soalan untuk ditanya kepada Dr. Syahmi, sama ada boleh unmute yourself ataupun boleh type pada inbox untuk info messages untuk type soalan. Okay, tak ada soalan. So kalau tak ada soalan, saya nak summarykan sekali lagi yang kepentingan. Kalau ada mana-mana sampel yang sangat lipemic, bermaksud sama ada di klinik kesihatan ataupun di hospital, perlu pastikan bahawa sampel itu tidak hanya di-reject. Maksudnya you just beritahu, sampel ni lipemic, saya tak boleh buat analisa dan saya reject. Tetapi sampel itu sama ada yang pertama perlu notify kepada doktor bahawa the sample is very lipemic, which is this is warrant for further investigation. Kalau katakan bila buat analisa, biasanya untuk keputusan lain dia tak akan dapat bagi keputusan. Tapi kalau untuk lipid profile, TG ataupun kolesterol, kemungkinan analisa itu boleh dibuat tapi dia akan bagi more than test. So untuk lipid profile, kita tak akan analisa ujian selepas daripada high speed certification. Jadi di mana-mana hospital tu dia kena buat that lipid profile supaya the high lipid profile tu akan warrant that this patient actually possibility to have familial hyper-TG, for example, in this kind of patient. Ini maksudnya macam tadi, kalau familial hyper-TG is just a tip of iceberg. Maksudnya the patient need to be investigated because the high risk of angina ataupun MI, cardiac event, dan dia juga perlu screening for all the other sibling and children kalau kan ada. So maksudnya benda ni is important. It's not just like I cannot measure because lipemic and we just think that this is a pre-analytical error disebabkan oleh a non-fuzzy sample. This kind of sample is not a very, as simple as ask patient to fast. This is some sort like underlying medical condition that require attention, and it must be clearly communicate with the physician ataupun doctors in charge to make sure that we don't miss this kind of patient. So maksudnya yang tu kena communicate dulu. Yang kedua, untuk center yang tanpa high speed centrifugation, we have to centrifuge the sample, aliquate the serum and plasma yang Lipaemic tu, and then send to either in the mainland to Hospital Seberang Jaya ataupun di island part to Hospital Pulau Pinang, notify to the chemical pathologist or scientific officer di these two hospital so that we can high speed centrifuge and analyze the sample so that result can be generated to the requesting doctor. But the key point is it must be communicated. We must be well informed that this is not a simple or usual lipemic interference, but this is a very significant, profound or severe lipemic sample. This must be well communicated to the requesting doctor. Supaya dia tak just anggap this is just berlemak biasa je, but this is some sort like underlying medical condition. So yang tu sangat penting untuk kita faham lah. So Puan Zanara tanya kalau dari KK kami perlu inform dulu ke nak hantar sampel lipemic atau hantar direct ke HPP. So untuk di KK Seberang Jaya, Puan boleh hantar ke Hospital Seberang Jaya sebab Puan Hospital Seberang Jaya pun dah ada high speed centrifugation. Maksudnya just inform jugalah supaya kita get ready dan kita maklum bahawa yang sampel ini tujuan dia untuk apa, untuk high speed centrifugation supaya kita tak miss ataupun tak buat yang appropriate tindakan, dan seboleh-bolehnya kita nak laksanakan segera untuk lipemic sample. Tapi perlu diingat jangan hantar sampel yang tanpa centrifuge sebab dia akan mengganggu juga analisa berdasarkan stability of analyte disebabkan delay in centrifugation. Dan Encik Syafiq kita akan share slide lepas ni lah. Okay, ada soalan yang lain? Jadi saya harap semua akan faham dan ni, tapi kalau tak sure juga always boleh consult ataupun tanya pada beliau bermasalah. Tapi macam saya kata tadi, this is tip of iceberg that might be due to the underlying medical condition that might not affect the patient alone, but that may affect the whole family that need to be investigated. So don't make it limbo, some sort like first time datang to hospital or KK, we reject it, and then patient then turn up again, or come back the second time, we still reject, or we keep asking for a new sample to overcome, end up that patient don't have any clear dia punya patient clinical condition as well as that warrant for screening for other family members. Okay, so kalau tak ada apa-apa, Dr. Syahmi ada apa-apa lagi nak tambah?
Tak ada, okay.
Okay, so make sure that for the KK side, always we can communicate in the KK group, our WhatsApp group. And for the hospital, of course, you can just directly for the biochem Seberang Perai, kita ada our WhatsApp group Seberang Perai, and for HPP, you can communicate, balik pulau tu can communicate with HPP's team. Okay, kalau tak ada apa-apa, itu saja untuk hari ini. Saya harap semua dapat manfaat dan terima kasih atas perhatian semua.